fast-forwarding almost a decade. And I'm in my private practice and I'm doing therapy. I'm doing health psych focused on people who are living with chronic medical conditions like myself. I've lived since 2012 with lupus and fibromyalgia, and I really missed testing. And so I brought that back into my practice and started specializing in ADHD assessments for adults, and then adding in autism assessments because I started seeing that a remarkable number of people who were coming in late diagnosed were late diagnosed because they were able to mask or compensate, typically because they were also highly, highly intelligent, something that we call twice exceptional.
Twice exceptional.
Twice exceptional.
Right.
Maybe you have intellectual giftedness plus ADHD or autism or something.
Are you or someone you know struggling with ADHD or autism spectrum disorder symptoms? Then stick around, because in this episode of the Mental Health Toolbox, we bring back Dr. Monica Blied, psychologist and neuroscience practitioner, to talk to us about the surging emergence of neurodivergence. Dr. Monica Blied is a very experienced psychologist based out of Claremont, California, where she has a business called Faces of Health Wellness Center, and she specializes in the assessment of ADHD and autism in adults, something that's actually very hard to find. She is also the creator of an app by the same name, Faces of Health, which provides you with resources to support your mental health journey. You can learn more about the app and her services by visiting facesofhealth.net. If you'd like to learn more about her services around ADHD testing, you can visit her site at drblied.com/ADHD. Also, Dr. Blied will be presenting at the CAMFT Annual Conference, taking place May 5th through 6th. So if you don't want to miss out on that, be sure to subscribe at camft.org, where you can register and also get the replay. All right, with that, let's jump in. Hey, if you're getting value from this content and you haven't done so already, be sure to subscribe to the MHT newsletter. That way you don't miss out on any new content as it's released, and I have freebies waiting for you there as my way to say thank you. You can find the link in the description below. Welcome, Dr. Blied, back to the Mental Health Toolbox. So happy to have you back on to talk about your expertise in all things ASD and ADHD testing and diagnosing. And today we're talking about surging emergence of neurodivergence.
Yeah.
And why don't you go ahead and take us on this journey of figuring out why we are getting such a late diagnosis and why it's such a problem these days.
Yeah, I think, maybe I can start off with something that's relatable to a lot of people who are getting these late diagnoses. The people who are coming to my practice and that I'm seeing identifying themselves as late diagnosed ADHDers or autistic folks are saying like they first realized through TikTok. Through TikTok or through Instagram accounts, like, oh, wow, like this sounds a lot like me, or what this person is saying sounds like my lived experience from my whole life. Like, I wonder if maybe I'm not an alien. Maybe I'm not someone who's just really weird or quirky, but what my experiences have been can be better explained or best explained by a neurodiverse brain style. Maybe I actually have ADHD or autism. So just as an aside, I am talking about this in a workshop at the CAMT, the California Association for Marriage and Family Therapists annual convention next month. And so that should be recorded and available for people who cannot attend in person. But kind of just giving you a little bit of background on me. My heart is for assessment. Like I love assessment. Throughout graduate school, I was actually training to become a neuropsychologist. So my dissertation was in interhemispheric transfer time and looking at the corpus callosum on an electrophysiological like measurements. So I used EEGs, but part of that data was also like cognitive testing and structural and functional MRI data and SPECT scans, and like putting it all together as part of this research study at UCLA. And it was actually right when I was applying for internship. So you apply for internship during your fifth year of school. I went to Fuller Seminary, and then your sixth year is when you're doing the full-time internship. As I'm applying for internship, 5 years of neuropsychology training, I decided, you know what, I really like health psychology.
Of course, the last year.
Right. And so I disappointed all my mentors and advisors. I was just like, actually, I'm going to do health psych. I found out later, as an aside, that one of my advisors was like, good for you, Monica. It's really great. But coming full circle, so I did, behavioral medicine and looking at how, again, the physical body and our medical conditions, how those show up and impact someone's mood and emotional health. But isn't that super similar to what neuropsychology is?
Sure, sounds like it.
Brain. Right. We're looking at the brain. We're looking at how this biological organism impacts mood, behaviors, experiences. So fast forwarding almost a decade, and I'm in my private practice, and I'm doing therapy. I'm doing health psych focused on people who are living with chronic medical conditions like myself. I've lived since 2012 with lupus and fibromyalgia, and I really missed testing. And so I brought that back into my practice and started specializing in ADHD assessments for adults, and then adding in autism assessments, because I started seeing that a remarkable number of people who were coming in late diagnosed were late diagnosed because they were able to mask or compensate, typically because they were also highly, highly intelligent, something that we call twice exceptional.
Twice exceptional,
right. Meaning you have intellectual giftedness plus ADHD or autism or some other sort of neurodivergence. And the folks who were also being tested as ADHD gifted also said like, hey, actually, when I, was in college, one client in particular I'm thinking about, when I was in college, I used to go to bars to observe how people would talk and what their facial reactions would be, and kind of like put together what that meant. And so they were on their own understanding scripts for social communication and developing those scripts so that they could get by in life. This was someone who was a 25-year-old, African engineer or immigrated engineer who like didn't realize like, oh my gosh, like that's part of the autism spectrum. And so as I started to see these commonalities and co-occurrences, I wanted to be able to help. Fast forward to 2023. I'm 37 years old, and I get diagnosed myself with ADHD.
Wow, full circle.
Full circle. And then I learned later that the average age for diagnosis for women, so for individuals who are assigned female at birth, is actually 37.
No kidding.
Yeah. So I'm right on time. And some
right, I was going to say, who knew? Yeah.
And so as I was doing this, the specialty assessment, specialty meaning seeing a high volume of individuals who were twice exceptional, hearing their stories, hearing what their parents reported for behaviors in childhood, I was like, this sounds a lot like me. Like thinking about the past year, I would burn anything that that I cooked, basically. I was going to say, like, there wasn't water, but I'd burn water too. And then, like, how the pot just burns itself when the water is all boiled down. Until we got a Ninja. We got a Ninja toaster oven, and so that automatically turns off.
Oh, there you go.
Yes, I found ways to accommodate.
Right.
Or, starting things and not finishing them, being very highly organized and meticulous when it comes to work. But then home stuff, don't let me turn my camera. Don't let me turn my camera so you can see what's actually going on.
That's funny.
Things like that. And so I had attributed it to stress, stress, to life circumstances, that, and my husband is an ADHDer. He's autistic and ADHD. And so I was like, well, I mean, I'm not as severe as him, whatever I got going on, right? He's gonna watch this later, like, wow.
That's funny.
So it must not be that bad, not realizing even for myself that internalized stigma of like, okay, well, if it's not that bad, or if it's not that impairing, it must not be a problem. And so I went back even myself on childhood, reflecting back. ADHD and autism are neurodevelopmental disorders, which means it's a different in how our brains are structured, wired, and chemically balanced. And they're present at birth. In order to have ADHD, there has to be, according to our current diagnostic manual, there has to be some signs and symptoms before 12 years old. That's where the cutoff is now. And so I was thinking back to my childhood, and, I was the kid who on report cards got straight A's, but then the teacher comments would be like, talks too much, forgot homework, things like that. And I was like, this again sounds a lot like me, because part of my assessment process with my clients is to review all report cards starting from
I remember saying that from our last interview.
Yes, and reviewing those teacher comments. And so I asked my mom, and my mom, unsurprisingly, sounded a lot like the parents of the people that I assess. She said, girl, nothing's wrong with you. You always got good grades. And then she slipped and she said, now you may have waited until the 99th hour to start anything.
And that's the tell.
But you always did great, and aced everything. I don't know how you did it, but you did it. And I'm like, Mom, that is procrastination followed by hyperfocus. And so as I'm putting together these little clues and signs and trying to understand my own experience, I went to my psychiatrist who was already, treating me. And I said, I think that this is also going on. And he trusted my own clinical judgment and my, expertise and all that, and said, let's just try a stimulant. Let's just see. And again, my own internalized stigma, misperceptions. I said, I don't want a stimulant. I absolutely do not want. I will continue to manage by myself because I don't want to become addicted. I have addiction in my family, the family history. And so genetically, hereditarily, I'm like, I ain't trying to be like them, right?
Right. That's good insight to catch that.
Right. But I got the education, even with me having PhD, 3 master's degrees, bachelor, all that, I did not know that I was actually misinformed when it came to stimulants as a first-line treatment for ADHD. What the research shows is that ADHDers who are prescribed stimulants, it is actually a protection or a buffer against addiction. It helps to prevent addiction because that ADHDer then is getting the treatment they need and they're not self-medicating.
That makes a lot of sense when you think about things like methamphetamine, right?
Exactly. They're not seeking other things to try to kind of cope with what they're going.
Just to be clear for our listeners who maybe aren't familiar with stimulants in treating ADHD, it has like a paradoxical effect, right?
Yes, and that's what I was going to get to. So he was like, okay, Monica, he doesn't call me Dr. Blied because I'm like, I'm his patient, but like,
not because they need more energy.
and he's like, let's just try it. The very, very lowest dose, let's just see what happens. The benefit of stimulants is, immediately how it affects you, and it's in and out of your system versus an antidepressant, anti-anxiety, or antidepressant medication used for depression and anxiety and SSRI. It typically takes a number of weeks before you see how it works. And, there's a longer half-life and those sorts of things. A half-life is how long the medication stays in your system. So got a low dose and almost fell asleep. I emailed him. I was like, Dr. Van Dantham.
That's a good litmus test.
I was like, this stimulant is not stimulating. And he said, that's great news, Monica, because that's how an ADHD brain responds. Light bulb. 37 years not realizing that I had an unnecessary struggle. I was living with an ADHD brain. Yes, I was very smart and I got through, everything. 43% of adults with ADHD drop out of college. And so
that's a high percentage.
Yeah, I was very fortunate, very blessed that, there were other supports around me that made sure that didn't happen for me. And so again, this is not stimulating. He was like, that's great news. But then I started to, again, pull in additional information or additional, I guess, witness to what my experience had been all along. All my life, coffee did nothing for me. I would have coffee at night to relax, to kind of just calm down, or it'd be like my little treat if I wanted to just like get soothing or whatever. It was never stimulating for me. And I was like, oh my gosh, that makes sense. I recently began teaching physiological psychology at Pepperdine Graduate School. It's one of the classes that I took back when I was in graduate school in 2009. And so I opened up the book for the class that I took that I'm going to just started teaching. And I was like, wow, this should have told me something was wrong. First 3 chapters, and I can pull it out if you want. First 3 chapters, every word in line is underlined or highlighted, and there's notes on the, the margin. And just trying to keep up and trying to focus on what I'm reading. After those 3 pages, the book is blank because I gave up. And so I just, the way that I absorbed information was more from hearing. And so I would just pay more attention in lectures and, kind of interact, engage with the material versus like having to focus, sit down and read it. And it was torturous. And so there are these things all along that I missed, because if I'm comparing myself to, my male counterpart, for example, my husband, or if I'm comparing myself to what the media shows of what ADHD looks like, I'm not ADHD. I don't have that issue. I just struggle with time management.
Right. Which a lot of people can relate to.
Yeah.
You wouldn't necessarily think of it as like a red flag.
Right. Or an indication of, this is a feature of a neurodiverse brain style. We have this emergence of not just people assigned female at birth, so not just women, but also men who are late diagnosed, and usually those are the ones who present as more inattentive or internalizing of whatever hyperactive or impulsive symptoms that they may have. So although they may not interrupt people because they've learned, they are like right at the edge of the tongue, and they're not really focusing on what you said because they're holding that thought of what they need to say, right? Or internally they feel physically restless, even if they're not pacing back and forth, in the room. And that's typically how those sorts of features show up in adults anyway.
Wow. That's really, that's really enlightening to understand, like, that it's not just what, like you said, what we see in the news and what we see on TV and what's portrayed. It's not just that kid that gets in trouble in school for acting out or disrupting the class, right? It's sometimes a lot more subtle, and people can be a lot more savvy, and like you said, in how they compensate, right? They might still do well in school. They just might find some life tricks to get around it, right? The best they can.
Right.
And so then they might even get praised. Then you have that reinforcement. Oh,
Yeah.
this works when I wait till the last minute and I hustle, right? Oh, I get a lot of
Yeah, it's like
praise.
it's
I still
gonna
get
be
the
great. Why
A.
would I start earlier? And I would try. I
Right.
would try.
Yeah.
Yeah,
So, I
but
mean,
then we
so much
also
to
look at
unpack there, and even in your own experience. Why do you feel it goes, and I'm sure you're going to get into this, but why do you feel it takes so long to get caught and diagnosed?
there's so many different reasons, so many different contributing factors. I think for me personally, it was because of those compensatory behaviors. We gonna break it down and just call it excuses.
Mm.
Like I excused for myself, like, oh, I'm late because it's cultural,
Right.
cultural people time, or CPT, that kind of thing. Or I am just better at audiobooks, or like I just need to stay in the kitchen while I'm cooking, or just all these kind of
Mm.
excuses that we make of not really kind of seeing a horse for a horse. If I can pull out a really random analogy that no one's ever heard of before.
Mm.
So there's that. There's some like um, whether it be on a conscious level or not, but there can be some internalized stigma of like, well, what does it mean for me if there is something that's different about me? Or I've always felt different.
Mm-hmm.
I don't want something to confirm that I actually am different.
Right. The stigma.
I've always felt like an outsider,
Mm-hmm.
not really fitting in, or, kind of fill in the blank things. These things have been harder for me, but these things have been easier. And
Sure.
like, let me just deal with it.
Mm-hmm.
I'm okay. I'm
Mm-hmm.
getting by. And
Mm-hmm.
so when I don't want to say that the symptoms or the features are milder, because they're not, they're just different. But when a person is better able to manage it, then I think that can contribute. As well as that comparison game, comparing themselves to someone whose external features are more severe,
Mm-hmm.
even though internally it could be like chaos and
Mm-hmm.
anxiety and so many other things.
Mm-hmm. That makes a lot of sense.
Yeah. Yeah.
Yeah.
I have a little handout here that I'll share my screen of
Please do.
why people get missed, why you, or if a therapist is watching this, their client may have gotten missed.
Mm-hmm.
And after this, I do want to skip over to the late diagnosed
Yes.
autistic individuals using identity first language, because that's something that's really unique as well.
Love it.
Okay, let me share my screen. Okay, so why you or your client may be missed. This is what I've seen very often. There's already an identified patient in the family.
Mm.
So the time, support, the resources, the energy, the drama is going towards, your younger brother or sister who has an identified learning disability or who is not getting good grades. So you are skating by with B's or C's or A's, and oh, you're doing fine, versus this person is failing. The
Mm-hmm.
resources and attention is going to go to that person. Or this person has really disruptive mood disorders, and this is the person who's going to get the support, versus you have a lot of mood disorders as well, but it's all internalized. You're academically glowing. So no red flags for teachers. If you had a lot of obvious and academically impairing features in elementary, middle school, the schools are required to assess you. They're required to test you. I actually have had some clients as young as 8, 9 years old who are struggling. So parents are spending 3 to 4 hours on homework every night, even though it should only take 30 minutes,
Mm-hmm.
things like that. But it's not affecting them academically. They're
Right.
still,
They're just making
making
up for
good
it on the
grades,
tail
things
end.
like
Yeah.
that. So the schools won't test. So,
Right.
unfortunately for these parents, they do have to go privately. You're a daydreamer. You're compliant and not hyperactive. So again, being missed. Or you have an accommodating and nurturing home environment. So sometimes it's not that the parents are neglectful because they're, spending all their time, energy, resources on another sibling. Sometimes the parents have set you up where the parents are giving you those reminders. Like they have a
Right.
visible calendar and like, that whiteboard with the to-dos and things like that. So
Excessively supportive.
right, your parents are serving as that external frontal lobe or that executive functioning system for
I
you.
love that. External frontal lobe, right? That's
Yes,
a great
yes, and I've seen that a
description.
lot,
Yeah.
or parents have normalized the behavior so they're not problematic.
Uh,
And these go for both late diagnosed ADHDers and our our autistic folks who are not being diagnosed until adulthood. Like, oh, I had one family where like, oh yes, my daughter, gets dead bugs and dissects them and analyze them and things like that since a very young child. But like that's just her. She's just quirky. And then as a teenager, she's creating like resins and like these really fascinating, intricate things that showed that this was a preoccupation of hers. And I
mhm.
mean, she knew everything about the phylum, microphylum. Like I don't even
Mm,
know,
mhm.
there's different, species categories and things like that. But missing that this was actually a feature of autism
Mhm.
or inadequate resources. So even though the schools are required to test, the workarounds when you have inequity in systems is like, okay, yeah, we're going to test, but our waiting list is a year long.
Mhm.
So, or our waiting list is 4 years long. My kid will be in high school by then. My kid will be
Right.
graduated by then. So realizing that that is something that is real. A sibling or a family member has more functionally impairing traits or features. So yeah, I honestly believe if my family members were to get tested, I would not be the only neurodivergent person.
Mm.
Not be. I think just because I'm in this field and have this awareness, I got diagnosed, but like if you look
Right.
at the home, but if someone again has more problems related to it that are obvious or made public, then that person's going to get more attention. Being twice exceptional, meaning high IQ, they can get by, they have compensatory strategies. So like my phone, like my calendar is everything. And if
Mm.
somehow you don't make it to my calendar, meaning like we were talking about like, oh, let's get together, girl. And then I forgot to write it down. Literally, it didn't exist.
Not gonna happen. Yeah.
It doesn't exist. Just, so things like that. And then also misdiagnosed,
Mm.
missed opportunities. What the latest data shows is that typically individuals assigned female at birth, those girls and women, are diagnosed with this cluster. It's called the alphabet soup of diagnosis.
Mhm.
A restrictive eating disorder, OCD, and a trauma disorder, PTSD,
Mm.
and usually social anxiety as well before they're diagnosed with autism. In younger kids, you also see oppositional defiant disorder or disruptive mood dysregulation disorder or even conduct disorder when it's really like a reaction to being overstimulated or
Mm.
some sort of misalignment between the environment and their neurodivergent
So not
needs.
so much a comorbidity as much as an overemphasis on those particular symptoms without looking at the underlying problem.
Without the
Right.
context.
The
Yes,
context, yes.
because there are absolutely comorbidities, meaning both things are happening at the same time or
Hmm.
co-occurrences. But sometimes you get the chicken or you get the egg without the chicken. Like,
Gotcha.
okay, the egg had to come from somewhere, right? Like, like these things are actually together. Don't miss this. Because
Mm-hmm.
when you miss, that means that you're only treating the behavior, only treating the mood disorder, and you're not actually setting up that kid for success. You're
Mm-hmm.
not setting up that kid or that adult to be able to thrive in their environment by giving them a sensory affirming environment
Mm-hmm.
where they get the stimulation where they need it and they get, a little bit less, when they're needed, because everyone is different. Some people have sensory seeking versus sensory sensitivity. So understanding that and accommodating the environment. We live in a very neurotypical, accommodating world.
Mm-hmm.
Everything in our planet, on our society, unfortunately, here in the US, is typically set up for people who are non ADHD, non autistic. And so when we come to environments that are more understanding and embracing diversity,
Mm-hmm.
part of that embracing diversity is also going to be like, hey, do you need earphones?
Mm-hmm.
Or do we not have lasers, or those sorts of things, kind of recognizing what could be beneficial for everyone who's in the room.
Mm-hmm.
And then
That
also,
seems like something that would be easily implemented,
oh yeah,
with a
yeah, you
program in
actually see it
schools,
on
right? It's not a big
some cruise
ask.
ships.
Yeah.
What's that?
So it's not too big of an ask, right? Program
Yeah,
wise.
yeah, it's more of an awareness.
Mm-hmm.
I truly believe, I'm an optimist. I believe that people don't implement these supports because they're not aware. They're not aware that they're needed first or how to do it. You can feel kind of stuck and hopeless if you don't know like how to support this person with these brain differences. Once you know, then you can do it.
Absolutely.
And then the last thing is the denial, shame, and ableism. And I just wanted to bring up this next slide about how things show up differently in females, people assigned female at birth. So in autism, what do we see? Actually, you tell me this, Patrick. What is the typical caricature, I'm going to call it that, or the trope of an autistic person on TV?
Oh, definitely. Trouble with social interactions, pragmatic skills, social anxiety, hyper, like you said, hyper focused on particular interests. Definitely
Mm-hmm.
when it comes to emotional intelligence, that's, they have to learn the skills robotically as opposed to
Mm-hmm.
reading between the lines,
Mm-hmm.
things that
Mm-hmm.
they should just be able to read the room, can't
Mm-hmm.
typically.
Not
They
reading
have
the
more
room.
trouble with that, right? A lot of it
Yes,
is learning
yes.
scripts, social
Yeah,
scripts, and what's
yeah.
appropriate in a very particular context. But if that context changes, then they get very uncomfortable. Um,
Yes, yes.
yeah.
And you said that in a very, I think, evolved and sensitive way.
Mhm.
But I think, when most people see it, or when I see it, and I think our media in the past 5 years has gotten a lot better. But typically what you see is someone who's autistic is they talk like this and they have no variation to their
Mhm.
talk, and they're male, they're
Mhm.
white,
Mhm.
and they do not care about the feelings of others.
Mhm.
They're completely unempathetic. They're basically like shit jerks,
Yeah, it's a
And that is
great
not
description of how the media has portrayed it.
right. But that's not
Yeah.
that oh my gosh, that is so leaving out 99% of people who are living with autism, and the people who get missed because they see like, oh well, I'm not that impaired, like I can't be that, like I have some fluctuation and attenuation in my voice as I talk to people, that there's a prosody, or I actually have eye contact with people and so I can't be autistic, or
Mhm.
things like that. But it actually looks a lot different. One misperception of people with autism that I just want to be very public about this is that they're emotionless,
Mhm.
and that cannot be far from the truth. Having a
Absolutely.
stepson who's autistic, a husband who's autistic, and being in this field, that is not true. What is true is that they are very deep feeling people.
Mm-hmm.
Now, they may not be able to organically pick up what you're throwing if you're very subtle about your emotional cues of what's going
Mm-hmm.
on with you internally. But once you know, they feel very deeply
Mm-hmm.
about what your experience is. So
Mm-hmm.
much compassion, so much empathy.
Yeah, so much empathy. Yeah.
So yeah, just putting that out there. And then, what else about, females particular? They could be very social. So you think of, an autistic person's like they're antisocial or like they're
Mm-hmm.
super introverted or whatever. No, they could be super social, but how the conversation looks might be very different. And
Mm-hmm.
so the conversation might be more one-sided versus reciprocal. Reciprocal
Mm-hmm.
meaning you share information and then I ask you questions about that.
Mm-hmm.
And then I'll share a piece of information and then kind of a back and forth in conversation versus one-sided or just talking about special interests, things
Mm-hmm.
that like these are the things that like I love, it's my jam. But when we go outside of this, it's just like, okay, what do
Lost.
I say next?
Yeah.
Right.
Outside of
um,
the comfort zone, right?
yeah, they may have an intense interest in people. There are so many people who study people, sociologists, psychologists, who actually find out themselves that they were actually diagnosed, that they have the diagnosis of autism. In
Mm-hmm.
fact, this happened with one of my colleagues recently. She wrote a blog about it, a late diagnosis with autism. There's also social and societal pressures to fit in. And so, although eye contact is difficult, for example, because you're getting all this sensory information at once, there's this detail orientation to the brain. And so I'm not just seeing your eyes, but your eyebrows and that crack in your skin and like, all these things. It's a lot. And so for me to be able to focus on what we're talking about, it's easier for me to look away so that I'm not also
Mm-hmm.
getting all that input, right? But societal pressure to fit in, I'm still going to look at you, but I'm like training myself to do that. There's a conscious effort versus
Mm-hmm.
something that's more organic and not forced or strained or uncomfortable.
Yeah. I've thought about
Um,
this before, but I think about these conditions almost as a superpower as opposed to a
mhm,
handicap in a lot of ways. I mean, the
mhm,
ability to be extrasensory. We
mhm,
think
mhm.
about, not to minimize it, but like superheroes,
Yeah.
like Spider-Man, right? Get your spidey senses. But what you just mentioned, the amount of information and stimulus coming in, it's really learning, how to filter that.
Yes,
Right?
yes. And
But
you know what? I sometimes use the word superpower, and I know that people can like take offense to that. Like, well, it's
mhm,
not a superpower because I have these challenges too. But like, kind of just taking it at like what we mean by that is there are things that neurodivergent people can do that neurotypical people cannot do. And that those inherent strengths and gifts are things that we do not want to leave behind. And
mhm.
we don't want to minimize just because we're having so many challenges with adapting to this environment that wasn't set up for us.
Absolutely. Well, you think some of the
Yeah.
most quote, quote, successful or influential
Yeah.
people throughout history have not been your neurotypical, right? People.
Yes, yes, exactly. Some of the most brilliant
Yeah.
mind inventors and just I mean, our entrepreneurs of the world, just so
Hmm.
many people who are thinking outside of the box or thinking within the box, but seeing it in 4D
Yes. I like
and
that.
all these other things that we don't even think of, that
Hmm.
complex
The
problem solving and
possibilities.
those sorts of
Yeah.
things. Yes, yes. And so for girls, their special interest may be normal. So it may be not be like dinosaurs or collecting bugs, but it could be like video games,
Hmm.
watching the same TV show over and over, or listening to the same songs over and over, and those sorts of things. So it's important to
Hmm.
ask about their experiences because you might not know by just having a conversation. And then I have on here too, like how ADHD can look a lot different in females. But I did want to kind of talk about this Surging Emergence of Autism and ADHD together. And also helping people to understand that there is quite a bit of overlap between it. There's overlap in the brain structures that are involved and the brain wiring and so much. So, a lot of times I'm actually seeing people in my practice who think that they have both, but they really actually just have ADHD. Because they say, okay, yes, I have a short attention span. I have, poor time management or whatever these executive functioning challenges, but actually executive functioning challenges are part of both ADHD and autism. So you can have autism without having ADHD, just like you can have ADHD without having autism. Sometimes you have both. But then they'll also say, like, actually, I have like a lot of stimming behaviors. So like I have to like always have like a fidget, toy around, or I'm like constantly tapping my leg and those sorts of things. And those stimming behaviors, that's actually something that is in both ADHD and autism. Or I have sensory sensitivities. Like I cannot stand certain smells or certain, sounds and, frequencies or whatever just freak me out. Like I have to have, like my earrings in or something like that. Sensory sensitivities are actually part of the ADHD spectrum as well. And so, let me just show you this overlap chart. And it's not, it doesn't have everything, but it does have a lot that can help with our understanding of ADHD, autism, and also OCD. It's just part of this because OCD can have like those repetitive behaviors and things like that that you see in autism, but it's actually not, or it can be both going on. And so let's think about the overlap between ADHD autism, which is this medium purple and dark purple. Emotional dysregulation, interrupting conversations. Interrupting with ADHD is more of that hyperactive, impulsive. Interrupting with autism is more of like, actually, like, this is what we're talking about. This is, what is most fascinating for me. Auditory processing difficulties, being uncomfortable with eye contact, and also social anxiety. Lack of object permanence. If it's not there in front of you, then it just doesn't exist, right? Finding it hard to make and keep friends. So I see a lot of ADHDers who believe that they also have autism because of this point. But one thing that a feature that is very common in ADHD is something called rejection sensitivity. And rejection sensitivity is related to several parts of the brain, but particularly here in our ACC, our anterior cingulate cortex. And that part is hyperactivated and more voluminous in a person with ADHD. That is the part of our brain that perceives emotional pain and physical pain. And so when a person with ADHD has that rejection sensitivity, so when they perceive rejection or criticism, or they anticipate it, there's more activation there. And it is actually experienced almost like a physical pain. It is very like highly activating for that person. And someone with autism, can also find it hard to make and keep friends, but again, for different reasons. It's, not understanding organically kind of the nuances of social communication, the back and forth, versus having to learn like, okay, how was your day too, and learn those scripts and those sorts of things. And autism, although it's called autism spectrum disorder and attention deficit hyperactivity disorder, we want to think about these in a broader term, not just as a disorder, but a difference. Autism is a different way of processing the world, a different way of seeing things. Poor working memory, executive dysfunction, rejection sensitivity, really intense emotions, hyperfixations. So those special interests are actually in both ADHD and
Yeah.
autism.
See why this gets complicated. You're trying to diagnose.
Talking a lot. Yeah. And so when we look at evaluations, it actually can be quite complex in saying, like, do you have both? Or is it one or the other?
Mm-hmm.
And one of the primary tools that is used is actually a parent interview. Because again, symptoms or features look identical in adulthood. Sensory sensitivities, repetitive behaviors, social communication problems, part of rejection sensitivity as well can lead to an underdevelopment of social skills because we haven't put ourselves out there because of the anxiety and stuff that comes from it, like all these things, right? But when we look at how this person was in early childhood, infancy, and particularly the ages between 4 and 5 years old, that's when it helps to differentially diagnose or be able to say, like, oh, actually, this is autism. Between 4 and 5 is when we develop something called theory of mind, which is the ability to put ourselves in someone else's shoes. So during that parent interview, I'm asking questions about how did your child respond when you were hurt? Did they kind of look like, I'm not sure what to do here? Or did they automatically offer comfort? What was their imaginative play like? Did they have different scenes between the, action figures or the Barbies? Or was it only things that they had already seen on TV or seen their siblings do and they were repeating that? How did they respond to strangers, whether it be another child or an adult? Those sorts of questions kind of gives us clues to the neurology and also the neuro experiential kind of underpinnings of what's going on for this person and also what's not. So that, again, why is it important to have these labels? Why is it important to know exactly what's going on for you? So that you can get the support that you need.
Right. So we can help position people to live their best lives, to play to their strengths, right?
Yes.
Yeah, absolutely.
Yeah. So that's how
avoidable suffering. Yeah.
Yes. Avoidable suffering.
Which is why the work you do is so invaluable, right? And it's, again, I've said this before in our past interview, that the clients that I see, I'm always dumbfounded at how when there's adults seeking treatment or a diagnosis for adult ADHD or to be tested for spectrum disorders, it's very, very hard to find. Especially under the guise of like MACL or paid, that'll pay for that kind of testing or programs as an adult, forget it.
Right.
Right.
Or even having insurance, reimburse for it because insurance companies see it as not medically necessary.
Yeah. Even like the regional center, in my experience, won't take anyone unless they've had a childhood history of diagnosis and treatment. It's documented. Yeah. Right.
Yeah. So what can we do?
Right.
So if you are an adult and you have noticed these things about you and you have kids, get your kids tested. When my child was 2, I was like, okay, regional center, because all the regional center, testing is free under 3 years old.
Oh, that's good to know.
Yes. And so I was like,
write that down, everybody.
Family history. Yeah. Like we need, and there's a lot of rigidity, a lot of specific ways that things had to be done and a little bit of twirling around and like these autistic features. And autism was ruled out for her because she did have a lot of the reciprocity in her social communication. However, as she continues to develop more and she's nearly 4 years old now, I'm starting to see a lot more where I'm just like, okay, she'll probably be late diagnosed. She'll probably be late diagnosed because a lot of the tools and instruments that we have were developed on boys. 80, 90% on boys. And so as our field evolves and we start to understand more, then we can better equip our diagnosticians or equip our psychologists and therapists, and then they can, give more accurate diagnoses. But until then, we're just going to provide that nurturing, supportive environment that will help her to thrive.
Absolutely. Well said. Do what we can, right? And who's in a better position than you to kind of know how to do that, right?
Oh, yeah, my husband as well, with his lived experience and just having a lot of, compassion and patience along the way.
Mm-hmm.
With the emotional dysregulation and all the ADHD features that are certainly there. Yeah, but it's a process. It's hard. I tell my parents that I work with, it's hard raising a future president, future CEO.
There you go.
Because they're bright and they got these, challenging behaviors as well.
Mm-hmm. Yeah. Excellent. So you'll be speaking more in depth on all of this, you said in May, right?
Yes.
Can you speak a little bit more about that and how we can sign up and learn more?
Yeah. So I'll be giving one of the presentations at the California Association for Marriage and Family Therapists conference on, I think, May 6th.
Mm-hmm.
So you can find out about that at camft.org, camft.org. And I believe the presentation might be recorded. And so if you cannot, change your plans in the next week to try to make it live there in Santa Clara, California, you can purchase the replay. And I'm sure there'll be bits that I'll be posting to my social media or YouTube as well once I get access to that.
Of course. And as always, I'll be sure to link up to all of that in the show notes.
Thank you.
So if you're listening to this, it's time sensitive. So be sure that you, and if you want to maybe catch the replays, maybe not, but definitely check out the show notes or look in the description, whether you're watching this on YouTube or listening on the podcast or reading the blog, the information should be there so you don't miss out. If you want to learn more about the world of diagnosing and treatment of these conditions, ADHD, autism spectrum disorders, especially in adulthood. So.
Yes. And follow me, subscribe on YouTube.
Yes. And you have your own channels. So definitely check out Dr. Blied on her YouTube and her Instagram and everywhere that you put out your great content, Facebook, right? I see you everywhere. So probably LinkedIn. Yeah.
Yep, LinkedIn as well. Well, thank you so much, Patrick, for having me today. I hope this was helpful for your viewers, that they feel a little more seen and understood, and perhaps even more self-accepting. It's been a process and journey for me, as it has been for my clients. But just know that you are not alone. Yeah. If you feel like an island, there are many little islands next to you. So
I love that. There's a tribe. There's always a tribe. And with a tribe, there's resources, right?
Yeah.
There's resources, and you never have to feel alone. And in working with clients on the spectrum myself, I'm not an expert. I'm not certified to diagnose, treat specifically ADD, ADHD. It's not my niche. But the clients I have worked with, I know that loneliness is a big problem. Feeling isolated, feeling disconnected, missing out. Especially as they get older. The clients I've worked with, obviously I treat mostly adults, that's a big problem. Feeling alone as an adult when you're on the spectrum is a huge problem. If you feel like you're not, quote, where you should be in life, if you're not checking the boxes, or even if you are doing well in one particular area, usually missing out in the social area. So
it's knowing that it doesn't have to continue this way. It doesn't have to continue to be a struggle. Yeah. There's support out there for you.
There's support, there's resources, and if you find anything helpful, be sure to share it with others so that we can get the word out that there are these resources available.
Yes.
Well, thank you so much, Dr. Blied, for taking your precious time to share these things. And if you're listening to this on the podcast, be sure to check out the video, because she shared some great slides that you would benefit from. So, all right. Well, as always, you're welcome to come back on and share some more, and happy to have you anytime.
Thank you.
My pleasure. Take care. Hey, if you're getting value from this content and you haven't done so already, be sure to subscribe to the YouTube channel and podcast and share with friends and family. It helps to raise mental health awareness. Well, there you have it. Another tool to help you thrive. Until next time, keep making good things happen. Bye-bye. The surgence of, say it again?
The surging emergence.
Yes, we're here to talk about the surging emergence of neurodivergence. Dr. Monica Blied is a very experienced psychologist based out of Claremont, California, where she has a business called Faces.